Good morning. Thank you for joining us. I'm Bill Fearon from Stanford, California, here with Dr. Gary Mintz as my co-moderator. We have a panel including Dr. Bainey, Dr. Choi, Dr. Flaherty, Dr. Goldberg, Dr. Lam, Dr. Sadamatsu, and Dr. Yoon. And this is a session on the ongoing and future randomized controlled trials from the Asan Medical Center. We'll have I think 4 talks and then a short period of discussion followed by 4 more talks and discussion. We'll start off with the RENOVATE trial, DOACs versus Warfarin for mechanical aortic valves. Dr. Joon Bum Kim will present.
Thank you for inviting me to this wonderful meeting. I'm so happy to present our randomized trial now undergoing in collaboration between cardiac surgery and cardiology groups in South Korea and led by Asan Medical Center. So as you all know, the 2 unique types of prosthesis has its own risk of thromboembolism and hemorrhage in mechanical valve, and biovalve has a durability issue. In the end, the most important outcomes should be survival. In the interest of evaluate the survival outcomes between the 2 prosthetic types, we looked at the Korean National Database, which was published very recently. It covered patients undergoing aortic valve replacement in the adult age group, enrolling 15,000 patients over the entire South Korea. When it comes to the younger patients, less than 55 years old, then survival was better with the mechanical valve, while middle age group also showed a better survival in mechanical valve than biovalve. Over 65 years old, the outcomes were the opposite. The biovalve had less mortality rate over the course of 15 years. So when you take a look at the spline plot to see the cutoff age level, we could find 67 years old was the cutoff to differentiate the survival between the 2 types. Meanwhile, we have seen rising trends in the use of biovalve in the middle age group, and the contrast is greater in the Western country, that over 90% of middle-aged group receive biovalve replacement, despite the survival analysis show better survival with mechanical valve. What if we make use of the DOAC instead of Warfarin that have shown better safety and efficacy in patients with atrial fibrillation? It has only fixed doses and no alcohol food restriction, and blood testing is not required. And is it reproducible for mechanical valve? 12 years ago, first randomized trial was published in New England Journal of Medicine. In this particular study, the study failed to show benefit of DOAC. In reality, DOAC showed a higher risk of thromboembolic event as compared to Warfarin, and bleeding event was significantly higher with DOAC. So why is that? When you take a detailed look at this trial, the dabigatran, which is factor 2 inhibitor, is less effective as compared to factor 10 drugs that are now we use. So drug choice may be not optimal. And secondly, in this trial, they did dose escalation based on blood testing, which is not practical in our real world. And then they also used a very high level of dosages in this trial. Thirdly, timing of medication was not optimal because they enrolled early phase of surgical period within 3 months, and the majority of bleeding occurred within this period. And finally, valve position also involved mitral position, which is much more thrombogenic than aortic valve. So, in order to better look at the lower risk group like aortic valve replacement, a recent PROTECT-HBR trial tried to evaluate the DOAC versus Warfarin in the similar issue. So in this trial, they randomized patients undergoing aortic valve replacement, they used apixaban instead of factor II inhibitor, and they did not do any blood testing or dose escalation. And they only involved 3 months post-op patients, and mechanical LVR only were enrolled. In the middle of the trial, the trial was dropped because of the significantly higher risk of thromboembolic event in apixaban group as compared to warfarin group. And the risk of thromboembolic event was threefold higher than warfarin group. It is almost near to those who does not receive any anticoagulation after mechanical LVR when you see the prior studies. And then when I take a look at the detailed subgroup analysis, most of all the major events occurred in American white, and there were non-white subgroup ethnicity, and there was no event in apixaban group in non-white, as you can see here. In our trial, RENOVATE trial is unique as compared to prior trials. In this trial, we are supposed to enroll 1,300 patients with mechanical aortic valve replacement at least 3 months after operation. And based on the presence of atrial fibrillation and participating site, we are do stratification. And one group receives rivaroxaban 20 milligram once a day, and the other group receives standard warfarin therapy. It's a non-inferior trial design, and the primary endpoint is estimated to be 15% in the warfarin, which is the composite of death, thromboembolism, and major bleeding, and non-major bleeding. And then non-inferiority margin was given 5%, and based on statistical assumption, the final 1,300 patients are supposed to be enrolled. This is a multi-center randomized open-label trial, and the rivaroxaban group is given 20 milligram once a day, but for those with reduced renal function, they are given reduced dosages. Warfarin group is given the standard INR target. So inclusion criteria generally is supposed to enroll low-risk patients with any other contraindication to use this. So exclusion criteria are those with high-risk groups or the, mechanical valve in other position and the contraindication to receive new drugs. Now, with the addition of 2 centers, Donga University and Aju University, recently we now have 11 centers in Korea, and up to this month, last month, for the 2 years, we enrolled over 40% of our final target, and we have seen 20 to 30 major primary events that reached the number of prior randomized trial. Then whenever we take a look at the data from DSMB, we have not seen any serious issues to stop the trial. So I guess we have a new hope to see the new future. Thank you for your attention.
Very interesting to interventionalists who don't deal with this on a daily basis. The next presentation, Define DM Trial, presented by D.W. Park.
Thank you. So Coronary Share was packed with audience. I think a great debate with Greg Stone and David Taggart. This is the first time after Excel issue. Okay, so my topic is about already presented in the breakfast session is Define DM Trial, state-of-art PCI, bypass surgery for multivessel diabetic patient. So, and for multivessel disease, we have very different modalities, bypass surgery and the less invasive PCI. And look at the contemporary available, the data shows consistently favor for bypass surgery, and some data adapt hard endpoint, some data included repeat revascularization, and all data favor for bypass surgery. Diabetics is absolutely global epidemic. In the world, we expected 25 years later and 45% increase in diabetic. North America is 21%, even in Asia, 73% will increase type 2 diabetic. This is absolutely global issue. And look at the contemporary guideline. This is always the same over the last 2 decades. Bypass surgery was class 1. There is no room for elective PCI for multivessel diabetic patients. Just we can do PCI for poor candidate for surgery. This is a 2A indication. That was the same. Absolutely, we have a remarkable change in the drug-eluting stent and the PCI field and the medication. The revolution is remarkable, but no room for elective PCI for diabetic patient. However, in our practice, we do a lot of multivessel PCI for diabetic population. So looking at the contemporary guideline based on these 2 trials, VARIANT-2D trial and FREEDOM trial, VARIANT-2D is a revascularization versus OMT, and this is a PCI stratum, no difference, PCI and medication, and death MI stroke is the same. In the bypass surgery group, it's no difference in mortality, but the death MI stroke was bypass surgery better. The reason why reduction in MI in the bypass surgery group. And the FREEDOM trial, this is one of a randomized trial for a basis of a contemporary guideline, and the bypass surgery was good for the diabetic and multivessel disease, and all the data is very old data, and no use of the second generation drug-eluting, just the Cypher and Texas, no concept, 0% use imaging and physiology. Also 0% use SGLT2 inhibitor and the GLP-1 agonist, high dose statin concept absent at the time, and antithrombotic, other cardiovascular medication dramatically changed. Absolutely contemporary PCI there is a big revolution over the last 5 years. Many trials published in New England Journal of Medicine. Now is guideline recommended, class 1 recommendation, imaging guided PCI, as well as physiology guided PCI. There was a class 1 recommendation in the contemporary practice. Also, diabetics, all guidelines strongly recommended the diabetic coronary artery disease, GLP-1 receptor agonist, SGLT2 inhibitor should be given for diabetic coronary artery disease. And so, absolutely, we expected a totally different world with the updated PCI field. So Define DM trial, we are expected 1,400 patients, 1-to-1 randomization, state-of-the-art PCI, and the bypass surgery. And this is a non-inferior trial. We're gonna enroll the 3 vessel disease, visual estimation more than 50%. Exclusion criteria is left main and the recent STEMI. The reason why excluded left main, as mentioned, is Bill Fearon, and overall prognosis pattern is totally different. 3 vessel left main disease in the Syntax trial. So primary endpoint was hard endpoint, all cause death, MI, stroke. We will adapt a universal definition is MI. Also, we will evaluate the secondary analysis SCAI definition, and we will evaluate the QOL. And the sample size was based on the contemporary bypass surgery arm, 2-year, and all-cause death MI stroke, we guessed 10%. And we adapt the hazard ratio margin is 1.45, and the 80% power, and the sample size require 1,000, approximately 400 patients. And the FFR is widely used all patients in PCI arm, and the imaging is that's absolutely essential part in the PCI arm, and the final optimization will be done in the stented segment. And the bypass surgery group, it will be followed in the contemporary bypass surgery, and we should do bypass within 30 days. RIMA to LAD recommended, complete arterial revascularization is recommended. And for all patients, we try to use the SGLT2 inhibitor or GLP-1 agonist. Also, we will do formal consultation, special endocrinologist during hospitalization as well as during follow-up. So this is the schedule, and we will measure the quality of life. We will evaluate it up to 2 years, and then if funding is possible, we will do 5-year follow-up and the current status. And I'm very thankful for the Moderator Bill joined this trial, Kevin joined this trial, and we are now 95 center in 26 countries, Asian Pacific 7 center, European 20 center, North America 5 center, finally agreed to join the DEFINE-DM trial. This is still launched period. Until recently, we included 31 patients, and I think we guess and 2 or 3 years required to enrollment was completed, and this absolutely provided new evidence, and the contemporary PCI bypass surgery trial, low ejection fraction ischemic cardiomyopathy, stitch 3T, ischemia HF is actively on the investigation in diabetic patient. DEFINE-DM will provide the new evidence. Thank you for your attention.
Thank you, Dr. Park. Very interesting study. Our next presentation will be the FATE-MAIN trial, FFR versus Angiography-Guided left main PCI. Dr. Wee will present.
Good morning, everyone. I'm Seongbong Wee from Asan Medical Center, and I'm honored to be here to present the FATE-MAIN trial. The FATE-MAIN trial aims to evaluate and compare two approaches, FFR-guided PCI and angio-guided PCI in patients with left main coronary disease. Our hypothesis is that FFR-guided PCI will improve clinical outcomes compared to angio-guided PCI in patients with left main disease. Now, let me show you why the FATE-MAIN trial is necessary. One of the key reasons is the visual and functional mismatch often observed when assessing left main coronary stenosis by angiography. According to the current practical guidelines for left main disease, revascularization is recommended for significant left main disease, which is defined as angiographically over 50% stenosis based on very old literature. And but what is the significant stenosis of the left main? And in the left side of the figure, significant stenosis is evident, but the right side is not. But what is the gradient of this kind of the region? Is very intermediate region, so we don't know the exact significant stenosis of left main. And to give a represent example, the images on the as shown in the both image, it's not clear which one is the significant stenosis. But when you actually perform the FFR, the left side is confirmed to be 7.1, the right side is 8.9. When confirming with the IVUS, a significant the atherosclerotic burden can be observed on the left figure in the previous slide. On the other hand, the MLA was 13.9 on IVUS, showing that the lumen was quite enough in the other case. So I'd like to show you to represent cases. In the first case, the angiography on the left side showed the intermediate disease in the left main coronary artery. And an IVUS, MLA on the left main was 3.9, and FFR was measured, which was 7.9, so indicating functional ischemia due to left main disease. Based on the FFR value, we treated left main disease, and the following is the final angio after PCI. And second case, the cranial view on the right side showed that there's the severe stenosis in the LAD with intermediate left main disease. And the left side caudal view revealed the tight disease in the sock as well. The FFR values are measured at 7.0 on the sock and the 6.8 on the LAD. And we may be confused about whether to perform the FFR measurement for left main disease, LAD or sock. Additionally, it is questionable whether the FFR for left main disease will be negative or positive. To eliminate this distortion of the true FFR value of the left main disease, we treated LAD and sock first. When we performing the PCI at the LAD and sock, the left main was checked with IVUS during the pullback, showing an MLA measured 4.75. There's still confusing information about what the FFR of the left main will be. As shown in this slide, after treating both SOC and LAD, we insert the pressure wire fall discharge into both the SOC and LAD, check the FFR, and is measured as the 8.4 in the SOC and 8.1 in the LAD. Accordingly, the treatment for left main coronary artery disease was differed. As such, there is a significant mismatch between visual and functional assessment in left main disease. In prior literature has reported a mismatch of 29% to 37% in intermediate left main disease cases. Thus, decision-making regarding revascularization in left main coronary artery using only angiographic assessment may be inaccurate. Next, we'll briefly introduce the previous studies on the intermediate left main disease. In the AccelSalicylic trial, the revascularization was performed when the diameter stenosis was over 70%. Based on the studies shown previously, the revascularization was performed in 80 to 70% stenosis cases. If there was an evidence of the ischemia in a non-invasive test, or if the MLA under the 6.0 on IVUS, or FFR was 0.8 or less, and then the PCI was undergone. The pre-combat trial showed that there is a lot of the intermediate disease in the left main disease, indicating that approximately half of the cases were intermediate stenosis. Therefore, current guidelines recommend the revascularization for left main disease that shows significant stenosis of more than 50% on angiography, although there are several limitations in evaluating left main coronary artery using angiography alone. The FATE-MADE trial is expected to provide a rationale for optimal decision-making regarding revascularization through physiology guidance, particularly for intermediate left main disease, which is difficult to evaluate using only angiographic assessment. FATE-MADE trial is a multi-center, international, and randomized control superior to trial, and patients with angiographic significant stenosis over 50% will be randomized in a 1-to-1 ratio to either FFR-guided or angio-guided PCI. The primary outcome endpoint is a composite of ORCOS tests, MI, rehospitalization for unstable angina, heart failure, resuscitated cardiac arrest, or lipid revascularization at 2 years after randomization. As mentioned earlier, patients with target lesions that are feasible for PCI among de novo left main coronary disease showing stenosis of more than 50% on angiography. The exclusion criteria includes several key conditions. Patients with LAD and SOC CTOs are excluded, although LCA CTOs are allowed. And extremely calcified or tortuous vessels that are difficult to measure FFR are also excluded. And cases with complex coronary anatomy unsuitable for PCI also excluded. And other exclusions include the recent STEMI 7 days of randomization, cardiogenic shock, or prior randomization, the prior CABG, or the end-stage renal failure, or the liver cirrhosis, or the patient who have a limited life expectancy of less than 2 years. As follows, a total of 934 patients will be assigned, and 467 to FFR-guided PCI group, and 467 to the angiographic-guided PCI group. And the primary endpoint will be compared at 2 years after randomization. To date, the FATE-MADE trial has enrolled 19.3% of its target sample across a total of 50 multi-center sites. Thank you for listening.
So the fourth presentation and the last one in this first half is VARIANT-ICD trial, be presented by D.Y. Kang.
Thank you. I'm Dr. Do-Yoon from Asan Medical Center. What I present is the VARIANT-ICD trial that compares ICD, implanted converter defibrillator, versus medical therapy alone in variant angina with aborted sudden cardiac death. This is a very rare situation, however, relatively frequent in the East Asia, including the Korea and Japan. I have nothing to disclose. This is the patient that we began the trial. The 62-year-old male patient visited ER after the CPR with the aborted sudden cardiac death. The EMS, the EKG showed the pre-fib, and we checked the coronary angiography after the stabilization of the patient and did the ergonovin provocation test. And after the third dose, you could see the total occlusion of the LAD with the vasospasm, with the ST elevation and the typical symptom. And it was totally relieved after nitroglycerin injection. And at the time, what was known was that it has some pro-clinical outcome in small studies. However, some has the pro-clinical outcomes, but we know that almost all vasospastic angina patient has a favorable long-term outcome. There were controversial results, and the only limited number of the patient was included in the studies and had a very short-term follow-up. At the time, 2008 ACCH HRS guidelines showed ICD therapy is indicated in patients who are survivors of the cardiac arrest due to VFib or hemodynamically unstable sustained VT to exclude any completely reversible causes. And is the coronary spasm reversible cause or not? No one knew that. And we gathered the data from the 13 heart centers in South Korea between 1996 to 2014. And 188 variant angina patients experienced aborted sudden cardiac death and other 1,800 variant angina without a sudden cardiac death event. And the baseline characteristics show that the younger age and the lower frequency of the hypertension and more frequency of the ST elevation during the event in the patient who experienced the acute aborted sudden cardiac death. And when we followed the patient in the retrospective registry, the rate of the cardiac death or death from any cause was significantly higher with a patient who experienced aborted sudden cardiac death. Maybe those patients would have some vulnerability of the myocardium or vulnerability to the fatal ventricular arrhythmia. The ventricular tachyarrhythmia, cardiac death or ventricular tachyarrhythmia rate was 20% and 30% in 10 years. Some patients received ICD implantation without the insurance coverage or reimbursement. And those patients showed lower rate of the cardiac death at 10 years, 4.3%, compared with the no ICD group showed about 20% of the mortality. And there was 6 appropriate ICD treatment that would save the patient's life. With this finding, we designed a clinical trial to investigate whether ICD implantation really reduced mortality compared with optimal medical therapy alone in patients with variant angina manifesting as aborted sudden cardiac death. This is the scheme of the variant ICD trial. We are enrolling the patient with the variant angina manifesting as aborted sudden cardiac death as a first event with out-of-hospital cardiac arrest due to documented VFib or sustained VT. We need EKG. And successfully resuscitated without poor neurologic outcome and variant angina diagnosed by the coronary angiography and no organic heart disease associated with the cardiac arrest. And those patients are randomized to ICD implantation versus medical therapy alone, the standard treatment. And the primary endpoint at 5 years was the death from any cause. Those are inclusion criteria. We are collecting the patient with the clear evidence of the ventricular arrhythmia and variant angina with the ergonovin provocation coronary angiography. The definition of the positive result is total or subtotal more than 90% luminal diameter narrowing. And exclusion criteria is organic coronary or heart disease or other history or the history of the arrhythmia. Primary endpoint is a 5-year death And secondary outcome would be the cardiac death or other deaths, and the recurrence of the ventricular arrhythmia, and the appropriate IC therapy or inappropriate IC therapies. And optimal medical therapy is guideline-directed therapy with the management of the daily life and CCB, long-acting nitrates, and Nicorandil if needed. The ICD implantation is supported by the Medtronic, thanks to the Medtronic, and the single coil ICD will be implanted according to available clinical practice guideline within 30 days after randomization. And the sample size was calculated under the basis of the previous the registry data with 140 subjects, 70 and 70 in each patient. The assumed event rate was 3% in ICD and 15% in OMT arm at 5 years. And after that, the guidelines was some updated with the result of our data and other registry data. In US guideline, the inpatient resuscitated with the sudden cardiac death with a spasm, the ICD was recommended as 2B and B recommendation. And next year, updated ESG guideline recommended that sudden cardiac death survivors with a spasm, implantation of an ICD should be considered as a 2A. However, the level of evidence is still C. So with the registry data and expert opinion, the guideline recommends to consider the ICD implantation on those patients, but there's no robust data. And we believe that the result of this randomized clinical trial will show the robust evidence of the benefit of the ICD implantation for those patients. However, the problem is the low enrollment speed. Those patients are very rare, so we are enrolling from the 23 hospitals all over the country. However, still only 3/4 of the patients are enrolled, and we are doing our best to enroll the patient. Thank you for your attention.
Excellent, thank you. Very interesting and provocative study. We have a few minutes for discussion, and so if any of the panelists have questions, just go ahead. I'll start off, and I'd like to ask Dr. Park about the DEFINE DM trial. We're looking forward to participating in it. It's an exciting study. I had two questions. The first is regarding your decision to exclude left main, and I just wondered if you could comment on, how the steering committee decided to do that and what the rationale was.
Yes, as you mentioned, initially we tried to include the left main disease, and in the steering committee we discussed including the SJ Park, and the cardiac surgeon is also think about the left main and three vessel disease totally different. Also in the syntax study shows some different prognosis. In the without left main three vessel disease, much poor prognosis, and the left main disease is quite equivalent outcome PCI and the bypass surgery. Also guideline not combine left main and multi-vessel disease. That is the reason why we are just included three vessel disease.
Great. I think I agree. I mean, I think they are different entities. I think it's a higher bar doing just multi-vessel disease. I mean, from our experience in the FAME-3 study at 3 years in our subgroup analysis, there wasn't a significant statistical interaction with diabetes, but if you look at the diabetic patients, the ones that got PCI compared with CABG, had a strong trend to higher death, MI, and stroke rate. Now, they didn't have the optimal medical therapy because the study was started and run before a lot of these agents were available. I wondered, my second question is, how are you going to monitor whether patients are actually getting the medical therapy, and also whether it's effective? Are you going to be doing laboratory studies, and are you going to be checking whether they're taking the medicines, that kind of thing?
Yeah, so I think that is the most important in diabetic, and totally medication different. First, SGLT2 inhibitor, GLP-1 agonist, many trials showing cardiovascular reduction in mortality and stroke, even MI. So we are fully recommended in each center, formal consultation with the endocrinology and concomitant follow-up and endocrinology. Also, we are provided as important, tool to educate the patient. We will try to each center very aggressively the monitor LDL level and receive the high dose statin as well as a very updated medication. I think for diabetic medication is now remarkable change. That is the important, one of the important issue about our DEFINE-DM trial.
Yeah, I would agree. I mean, in the FAME-3 study, when we looked at medical therapy compared with Syntax, for example, 90% were on statins, whereas in Syntax it was only 70% and higher rates of other medical therapy. And I think it led to lower rates of death and events in both groups. And so I think it's something that we really need to pay attention to. So thank you.
I have a question for
Yeah, please go ahead.
DW as well. DEFINE-DM is a fascinating study, and congratulate you on doing this. When I think about this, obviously it's a contemporary, contentious question. We just came from a left main debate in the other room. What I find fascinating is you're trying to compare contemporary CABG versus contemporary PCI and have meant or encouraged arterial revascularization in the CABG arm. For the PCI arm, how are you going to define patients that achieve complete revascularization? And the second question is those that go on to get image-guided PCI, are you going to provide guidance for MSAs that you should try and achieve as well?
Yes, I think that is most important. You are a key member of a complete trial. In our trial, we are recommended the complete revascularization bypass surgery, and in PCI arm, in the means of complete revascularization, we recommended the wide use of FFR, all PCI arms. So absolutely functional complete revascularization was recommended, not anatomical. Is FFR, even though diameter stenosis is 6%, FFR more than 0.8, that would be some medication yet. And the second question is about the right.
Yeah.
So, and our trial is a pragmatic trial. We are recommended contemporary, optimization guideline, but considering safety margin, although we are recommended optimization guideline, some physicians do not achieve that guideline, but we will emphasize contemporary optimization guideline.
CABG is better than PCI regarding two concepts. First is complete revascularization. Second is prevention of future disease progression, right? Previous study showed CABG is better than especially revascularization rate. But your study, primary endpoint excluded revascularization. So what is
that is
your
a
opinion?
very important point, and we are multi-industrial sponsorship. Nobody agree, including repeat revascularization. Also, many physicians fully agree. Hard endpoint, primary endpoint, death MI stroke is agree. That is the same in the Excel trial. Absolutely, Professor Gimmons mentions if you included repeat revascularization, absolutely, PCI failed. So the reason why we just include the hard endpoint, the death MI stroke.
Great, thanks. I wanted to ask Jim Flaherty about the first study, which is a very interesting one, the RENOVATE DOAC, looking at the role of DOACs. I'll be interested to hear how intense the DSMB is monitoring this. But before we get to that, I just wondered about your thoughts about the lifetime management of AS. And do you think that we will be moving away from mechanical valves, meaning, if you have a 50 or 60-year-old that either has a bicuspid valve that's amenable to TAVR or doesn't have a bicuspid valve, has no other indication for surgery, can you make the argument, go ahead and do the TAVR up front, and then, if it fails in 10 years, they're in their 60s or maybe early 70s, they're out of the range of even needing a mechanical valve, they could get the bioprosthetic and then hopefully, get TAVR'd the rest of their lives if needed. Does that make sense to you? I mean, I know there's data that in higher risk patients, TAVR explant is associated with morbidity and mortality. I don't feel like in low risk we know whether a TAVR explant is an issue or not. And maybe we can also get a comment from our cardiac surgeon about that, but go
I
ahead.
think it's a timely question. In our own experience, it is very uncommon for somebody over the age of 50 to get a mechanical valve these days in the aortic position. Typically, those between the age of 50 and 65 are still getting a surgical bioprosthetic. But we have many patients in an age range that come to us and ask for TAVR. And it creates a dilemma of, can we forecast maybe a 3-valve strategy in these patients? And what is that? What is the sequence of events that will get them to the rest of their life? Is it TAV, TAV, TAV? Is it TAV, surgery, TAV? Part of it depends on the anatomy and what your choice of first valve is. And, is that second procedure going to be set up for a second TAV, maybe a third TAV? So, I think part of this equation is 10-year plus data on TAV. We don't have great 10-year because when we were doing TAV trials 10 to 15 years ago, they were in high-risk patients and elderly, and they didn't live 10 years. But with low risk and early TAV trials now, with approaching 10-year follow-up, I think we'll be able to better say, you're going to get this amount of longevity on your TAV valve, and maybe it's similar to what you'd get surgically. So I think these are great questions, but they're not, we don't have enough data yet to be confident. I really like the design of this trial. I think he adequately pointed out the flaws of the earlier trial, particularly in the aortic position with the onyx valve. It would offer patients a great option if rivaroxaban can replace Coumadin for those that do elect to get a mechanical valve in the aortic position.
Yeah, and I wanted to hear, Dr. Kim, how intense is the DSMB monitoring? And you mentioned, I think you alluded to the fact that they've looked at things so far and everything looks good. Maybe you can just elaborate on that a little.
So during the contemplation of the study design, PROTECT-10A trial started, and in the middle of the summer, we saw that PROTECT-10A trial failed. So we were threatened to stop the trial because of the danger of such a great risk of thromboembolism. So we started very rigorous monitoring. So now for every 10 primary events, we review unblinded so that we compare between the two groups in terms of primary endpoints. And now we are reaching to 30 primary endpoint, which is pretty comparable to prior 10A trials number of primary events. And now still we are, DOAC is ahead of Warfarin. And then I speculate that the maybe if the trajectory is pretty similar up to now, then we may be able to finish the trial and possibly demonstrate the comparable outcomes with DOAC. Then quality of life in mechanical valve patients will be pretty nicer than now. And then when I see the data from the United States, the outcomes are pretty similar. So recently, ASTES database evaluate over 100,000 cases of AVR to take a look at the survival outcomes between the mechanical and biovalve. And surprisingly, the results were pretty similar to Korean data, indicating that the age cutoff for better survival with mechanical valve is almost 65. But the practice pattern in the real United States is opposite. Over 90% of age 50 or 60s are receiving biovalve because of the pursuing for better quality of life. If with DOAC, then we can say that mechanical valve works maybe better than biovalve without a lower risk of reoperation later on. So who knows the future?
Dr. Kim, was rivaroxaban selected based on any preclinical study or some pharmacologic study?
Honestly, we try to use apixaban because it's prototype drug, safest and most effective in the atrial fibrillation study. But we could not have sponsor from the company, so we switched to easier, cheaper one. But the beauty of the rivaroxaban is that apixaban has double dose a day, which has a compliance issue in individual patient, but a single dose a day is a strength of rivaroxaban. So maybe that is maybe one of the differences between the prior PROTECT-HBR trial and our RENOVATE trial, because the patients are much more compliant than a double dose a day.
Dr. Kim,
Okay.
can I just ask a follow-up?
No, we are out of time, sorry. So we're now going to go to the second half of the session. You want to introduce? Okay.
Sure. Go ahead.
All right, so our next trial is ASA 3C trial presented by Dr. Kim.
Well, morning. I'd like to share with you one of our newly initiated study protocol. Hopefully that will begin next month. It is called aspirin and statin for primary prevention in individuals with severe coronary calcification. So we are investigating whether aspirin or high-intensity statins can effectively reduce cardiovascular events in this high-risk population. Our hypothesis is that both aspirin and high-intensity statins will reduce ASCVD risk in patients with severe coronary calcification. For aspirin, we are comparing it to no aspirin use, and for high-intensity statins, we are comparing them to the current guideline-directed statin therapy. So let's consider a typical patient scenario. A 65-year-old male patient who is asymptomatic and hypertensive with a CAC score of 447. And according to current guidelines, he's clearly a candidate for statin therapy. But the question remains, should we also initiate aspirin, and should we also use high-intensity statins rather than moderate intensity? Observational studies clearly demonstrate that higher CAC scores strongly predict future cardiovascular events. So when we look at patients with a CAC score of 400 or higher, their event rate over a decade approached 20%. However, randomized studies in the primary prevention setting have shown either no benefits or only marginal benefits, while consistently demonstrating increased bleeding risk. So as a result, the role of aspirin for primary prevention remains unclear, and especially for specific high-risk subgroups like those with severe coronary calcification. And how about statins? We know that the current guidelines recommend moderate intensity therapy for patients with CAC score above 100. However, what about high-intensity statins for those with a CAC score of 400 or higher? The real CAD trial showed a significant 20% relative risk reduction of high-intensity therapy, even in patients with stable coronary artery disease. So does a CAC score above 400 justify the use of high-intensity statins for primary prevention? So our study is designed as a 2x2 factorial randomized superiority trial. We plan to enroll and randomize 5,000 patients who have a CAC score of 400 or higher. Our primary endpoint is a composite of ASCVD events measured at 3 years, which includes CV death, MI, and stroke. Regarding the safety monitoring, we will be carefully tracking bleeding events and side effects, including myopathy and new onset diabetes. So our study will include participants between the age of 40 and 75 who have a CAC score of 400 or higher and at least one cardiovascular risk factor. And we are excluding patients who have established ASCVD with symptom, evidence of myocardial ischemia, significant bleeding risk, liver disease, or any other contraindications to either aspirin or statin therapy. So looking at the primary prevention trials, the relative risk reduction ranged between 11 and 19%. Our target population is expected to have higher risk compared to those in the previous trial. So therefore, we apply the maximum observed relative risk reduction and the 10% attrition rate. So we calculated that we need a total of 5,000 patients to account for potential dropout. So we believe that our ASA3C trial will provide evidence on how CAC scoring can be used to guide therapeutic decision in the primary prevention setting. Thank you for your attention.
Thank you. Nice presentation. Our next talk will be on the PROTECT-HBR trial presented by Dr. Park.
Thank you for kind introduction, Chairman. I am Hans Park from Asan Medical Center. This ongoing trial is PROTECT-HBR trial, which compare the potassium competitive axis blocker and proton pump inhibitor. Antithrombotic therapy in cardiovascular disease is necessary. However, antithrombotic therapy have potential risk of bleeding. Previous Cogent trial, concomitant PPI use in patients receiving the clopidogrel significantly reduced the gastrointestinal bleeding. However, in COMPASS trial, routine PPI therapy offers no benefit for upper gastrointestinal events in low GI risk patients. Current guideline recommended concomitant use of proton pump inhibitor is as class 1A in patients with aspirin monotherapy, DAPT, oral anticoagulation monotherapy who are at the high risk of GI bleeding risk. However, PPI have several limitations. Long-term PPI use have several adverse events and pharmacological limitation, and furthermore, significant drug-drug interaction, especially clopidogrel. The novel class of exit suppression agent, PCAP, potassium competitive axis blocker, have rapid onset action time and maintain a prolonged and consistent elevation of intragastric pH without the food. The hypothesis is that PCAP would be non-inferior to PPI in primary composite of endpoint at the 12 months. Study design is multi-center randomized double-blind phase 4 study, stratification with participating center and type of antithrombotic drugs. We divided to the tegoprazan group and rabeprazole group. The sample size is calculated with a non-inferiority design, and event rate will be 4% in PPI group based on the result from Cogent and COMPASS trial. Non-inferior margin was less than 1.4, and trial rate is about 10%, so final number of patients is 3,320. So we evaluated the primary endpoint at 12 months and primary endpoint at the high GI bleeding risk patient with cardiovascular disease receiving antiplatelet or oral anticoagulation therapy. The primary endpoint is composite endpoint of upper gastrointestinal clinical events during the 12 months. Each component are first, overt GI bleeding confirmed by endoscopy or CT, and overt GI bleeding from unknown origin, and bleeding of presumed occult GI bleeding with documented decrease in hemoglobin level more than 2 or decrease in hematocrit level more than 10% from baseline. And symptomatic gastroduodenal ulcer without evidence of gastrointestinal bleeding, and persistent pain or presumed GI origin, duration is more than 3 days, and with the underlying multiple erosive disease confirmed by endoscopy, and GI obstruction and perforation. Secondary endpoint is component of primary endpoint, and time from randomization to discontinuation of study medication due to the GI symptom or sign, and gastroesophageal reflux disease confirmed by the endoscopy, and composite of cardiovascular safety endpoint, death from cardiac cause, non-fatal MI, non-fatal stroke. Each component of composite cardiovascular endpoint and any coronary or peripheral revascularization and all-cause mortality, any potential side effect of PPI or PCAP. Inclusion criteria have 3 categories: cardio and vascular disease, and chronic use of antithrombotic drug, and high gastrointestinal bleeding risk. Patient must meet all criteria. Key exclusion criteria is active bleeding or hemostatic disorder, and concurrent use of PPI or PCAP within 4 weeks before randomization, and baseline severe anemia or thrombocytopenia, and severe renal failure or severe chronic liver disease. Now, in Korea, 43 centers participated in this study, and over 50% of patient enrollment rate will achieved. Thank you for your attention.
Thank you very much. Our next presentation by Dr. An is the ENAVO-TAVR trial.
Thank you for your introduction, Mr. Chairman. My name is Seongbong Wee. I'm a junior consultant at Seoul Asan Medical Center. This time, I'm going to give you an overview of ENAVO-TAVR trial, enabled-glyphlosion SGLT2 inhibitor outcome trial in patients with severe AS and HFpEF after TAVR. I have nothing to disclose. TAVR initially started with high-risk patient or inoperable patient, but the progress has been made with studies like Partner 1 and US pivotal core valve trial, and later Partner 2 and TAVI study expanded to intermediate risk group. And currently, the studies are being conducted for low-risk patients, gradually expanding its indications. Early TAVR trial presented at TCT meeting last year in late-breaking clinical trial session examined TAVR outcome in asymptomatic low-risk AS patient randomized to either balloon expandable TAVR or clinical surveillance. And TAVR significantly reduced composite of all-cause death and hospitalization from any cause. And another study presented last year was TAVR Unload trial, which examined TAVR outcome in moderate aortic stenosis with heart failure. And the study showed a positive trend, TAVR group having reduced MACE rate and heart failure hospitalization rate. And speculating what comes next for TAVR clinical trial, as aortic stenosis progresses, myocardial hypertrophy and fibrosis can occur. And even after aortic valve replacement, the recovery from these changes is often incomplete, and maladaptive cardiac remodeling can occur, leaving high residual risk, such as premature death, heart failure, or poor quality of life. So we need appropriate medical therapy targeting the myocardium, and such cardioprotective strategies such as RAS inhibition, ARNI, or SGLT2 inhibition can be considered before and after AV replacement in aortic stenosis patients. SGLT2 inhibitor work by inhibiting glucose reabsorption in kidney, but this agent can also promote erythropoietin production in the kidney, which increase the number of RBC, and that can help oxygen delivery to the heart. And this systemic effect can help reduce inflammation and increase circulating progenital cells, which can help restore the heart tissue. But the exact mechanism of action is not proven yet, and there are some diuretic effect and neurohormonal effect that can all work together for cardioprotection. Studies such as Emperor Preserve trial published in 2021 and Deliver trial in 2022 have examined SGLT2 inhibitor effect in HFpEF patient. And SGLT2 inhibitor significantly increased outcome in HFpEF patients. And HFpEF is a clinical syndrome with a normal or near normal LV ejection fraction. And with an aging population and increasing comorbidity, HFpEF is commonly seen in elderly patients undergoing TAVR. Published earlier this year, DAPA-TAVI trial examined the efficacy of dapagliflozin in patients undergoing TAVR, and all patients had a history of heart failure. And dapagliflozin resulted in reducing death rate from any cause and worsening of heart failure. So our trial, ENAVO-TAVR trial, involves 1,040 patients with severe AS and HFpEF who underwent successful TAVR. The patient will be randomized to either SGLT2 inhibitor group or matching placebo group. And the primary endpoint would be a composite of MACE, including death from any cause, myocardial infarction or stroke, or hospitalization for heart failure at 1 year. Enavogliflozin is a novel SGLT2 inhibitor administered at 0.3 milligram, which is equivalent to 10 milligram of empagliflozin or 10 milligram of dapagliflozin. And this enavogliflozin is actively being studied in other clinical trials for its efficacy in other heart conditions. So in our trial, a patient with symptomatic severe AF who underwent successful TAVI will be screened first. And the patient have to meet the criteria of HFpEF, including LV ejection fraction more than 40%, and evidence of structural heart disease, including LV hypertrophy or LA enlargement, with an elevated level of NT-proBNP as defined here. And these are our exclusion criteria. And the randomization will take place within 2 weeks after successful TAVR. The patient will be randomized in a double-blind fashion to receive enavogliflozin or matching placebo in addition to their usual medical care, including heart failure medications. And the stratification will be performed according to these factors. And our secondary endpoint include composite renal endpoint, rehospitalization from any region, changes in heart volume or function, and serial change in NT-proBNP level. And safety endpoint include hypoglycemia, GU infection, hepatic injury, decreased renal function, ketoacidosis, or events leading to lower limb amputation. SGLT2 inhibitors are initially developed for a diabetic population, and these are the complications that can occur. Currently, we have 37 clinical centers participating in this trial, and we have first successful enrollment in December 2024, and we are actively moving forward with our patient recruitment. So to summarize, ENAVO-TAVR trial is designed to evaluate the efficacy and safety of enavogliflozin SGLT2 inhibitor in patients with severe AS and HFpEF who underwent successful TAVI. And this trial can help us to understand whether SGLT2 inhibitor can offer any benefit for this challenging high-risk population. And we are very excited about this clinical trial and its potential contribution to the post-TAVR management and the broader field of heart failure. Thank you very much for your attention.
Thank you, Dr. Ahn. Nice presentation. Our final talk will be the tailored CHIP trial presented by Dr. Hanbit Park.
Thank you. I'm Dr. Hanbit Park from Gangneung Asan Hospital, Korea. Today I talk about our upcoming trial, tailored CHIP trial. Tailored CHIP trial is a randomized control trial, temporal moderated antiplatelet treatment and versus conventional antiplatelet treatment in complex high-risk PCI. I have nothing to disclose. Currently, guideline, the depth duration is mainly determined by clinical manifestation, and we also adjust the depth duration by considering by patient ischemic risk or bleeding risk. So, in stable coronary disease, the 6 months depth therapy with aspirin and clopidogrel is recommended, and in acute coronary patient, 12 months of depth treatment, aspirin and more potent P12 prosthesis or ticagrelor is recommended. However, these days we are many performed complex PCI such as left main and CTO and multiple PCI. However, the complex PCI with the complex lesion is compared with the simple lesion is more major adverse cardiac event. So this Lancet paper, a complex high PCI defined by one of patient risk factor or PCI factor. Patient factor is the previous known ST elevation MI or ST elevation MI and recurrent ischemic events on dual antiplatelet therapy and history of stent thrombosis and chronic inflammatory disease such as rheumatoid arthritis and inflammatory bowel disease and diabetes and chronic renal dysfunction. And PCI factor is more than 3 to 10 and over 6 millimeter of total stent length and complex PCI such as CTO PCI and complex bifurcation requiring 2 stent technique and multiple PCI. So this patient has a increased ischemic risk, so in recommending for longer depth treatments recommended. So in European guideline, the prolonged depth duration may be considered in this complex high PCI to be level B. So optimal depth treatment of complex high PCI is still unknown. This is a key slide for our study. After PCI, most of ischemic event is early period. So ischemic is early period, but it then decreases ischemic risk. However, ongoing dual antiplatelet therapy is bleeding is persistent in the 8th period. And complex high PCI is more than ischemic risk, early ischemic risk. So we chose that temporal modulation of depth treatment is optimal treatment for complex high PCI. So for increased early ischemic risk, we designed by more early escalation, use aspirin and ticagrelor. And second, we reducing late bleeding risk, so we switching from dual antiplatelet therapy to clopidogrel therapy. Because we chose ticagrelor is based on the previous study. Ticagrelor is more potent P12 compared with clopidogrel. In PROTECT study, ticagrelor use of showed no incidence of composite vascular death and MI or stroke without increased major bleeding. And Optima study, Optima study is an randomized control test to effect on clopidogrel versus the low-dose ticagrelor and those standard dose ticagrelor on platelet inhibition. The platelet inhibition, let's see platelet inhibition. The low-dose ticagrelor and standard dose ticagrelor both post-TAVR show the lower PRU unit compared to clopidogrel. However, both the ticagrelor and low-dose ticagrelor and standard ticagrelor did not different PRET inhibition. So we chose that low-dose ticagrelor is a good option for reducing ischemic risk in complex aortic PCI. So our tailored CHIP trials are multi-center, open-label, and randomized control trial to different temporal modulated antiplatelet treatment and conventional antiplatelet treatment in high PCI patients with complex factor or clinical factor and lesion prostate characteristic. Tailored CHIP trial is sample size of 2,000 patients based on the previous studies, and randomized 1-to-1 and static randomization trial center or diabetes, and 10,000 conventional arm and 10,000 tailored arm. The primary endpoint of net clinical outcome. And our expand arm study tailored temporal modulated antiplatelet first 6 months aspirin 100 milligram aspirin and 6 milligram of ticagrelor, and then switching to next 6 months and clopidogrel monotherapy. And conventional antiplatelet treatment is for 12 months of aspirin plus clopidogrel. And study endpoint, the primary endpoint of net clinical outcome of all causes and MI and stroke and stent thrombosis and urgent revascularization and clinical neuropathy, BACC 2, 3, 5 reading. And secondary endpoints, each component of primary outcome and composite endpoint and any vascularization and major bleeding. And including test or above 18 years old and success PCI with the contemporary DES, and we define the complex high PCI. A complex high PCI is defined by lesion characteristics and clinical factor. Lesion characteristics left main PCI and CTO PCI and bifurcation with in two-stent technique and severe calcification and diffuse long lesion and lesion length is 3 mm or above and multi-base PCI 2 base and 3 stent recurrent stent implantation and 3 lesions to be treated and above 6 mm of total length. And clinical factor is diabetes and chronic kidney disease and severe LV dysfunction. And excluded and enzyme positive acute coronary syndrome, non-STEM, non-ST elevation MI, and ST elevation MI. And cardiogenic shock excluded and need for chronic oral anticoagulation and Warfarin or DOAC and active bleeding or extreme risk for major bleeding. And history of intracranial hemorrhage excluded and aneurysm excluded and LC and dialysis is excluded for bleeding risk. And current status from 2019 February through 2024 January, we total 2,000 was enrolled, and this late year, the primary data will be available. So our data give us insight to improve clinical outcome in complex aortic PCI. Thank you.
All right, we have some time for discussion. I'd like to start with the question for Dr. Kim. Simple question. This is a primary prevention study, but your follow-up duration is only 3 years. That seems really short to show a difference, particularly if you're using, variations of very standard therapy. I mean, I suspect your study is going to be negative, mostly because of a short follow-up duration, and that'll give them the wrong message.
Yeah, actually, Professor Jung-Min An designed this study. I think that he anticipated that some of the difficulty in enrolling patients, so he designed it as a 3-year outcome, but the total study period would be like 8 years. So we have 5 years of enrollment period, and then the last 3 years of follow-up period. So the total study will be expected like 8 or 10 years. So maybe, yeah, good comment. Thank you.
Negative benefit or harm of taking aspirin?
Oh, I think it would just be negative, period. Because if you think about what the typical patient population who's asymptomatic with a calcium score of 400 could be any age and you're comparing high statins versus non-high statins and a little bit of aspirin versus no aspirin. And, you know, I just think if there's an optimal treatment strategy, it won't appear in a short period of time just because there won't be enough events.
I do think the study addresses an important question because it's somewhere between primary and secondary prevention. The primary prevention trials in aspirin, we didn't know they had disease.
Yeah.
And here, they don't have events, but they have disease. So it's somewhere, it's like
1.5.
1.5.
Yeah, 1.5
And we don't have
prevention.
answers for that. And people,
No, I agree.
and I know the design challenges, but
No, I mean, he answered the question. You know, I think it's an important question, which is why I think the study design has to be maximized to answer that
how long do
question.
you think a follow-up would be ideal to see?
Well, at least 5 years, more likely 10.
You said you'll have up to 8 after the first
You're right,
3.
which is,
So the endpoint, although it says 3 years, it's going to be people up to, I mean, if you'll follow them.
Of course, yes.
Yeah. And I didn't understand it. The people who get randomized to not high-dose statin, are they on placebo or are they on whatever they want to be on?
The moderate intensity statin.
Yeah.
I just don't think you're going to have enough events to differentiate those two.
Yeah. I had a question about that. You know, we see this all the time, more and more commonly in clinic. I get these patients who show up, they're either primary care or their cardiologist referred them, and they're asymptomatic and they have a high calcium score. And except for patients that David Marin, the head of the ischemia trial, is one of my colleagues, sends, all the other referring physicians are expecting a cath in these patients. And sometimes it's hard to reassure them that you don't need a cath. And so my question was, how are you handling that? Like if they get a cath and they don't have disease, are they still eligible for the trial? Or if they have a CT angio, you mentioned that they can't have a positive stress test, but how does a cath work in?
You mean for this study?
Yeah.
If the patients undergo coronary angiogram, if there is no evidence of ischemia, the patients still can be enrolled for this study.
Okay.
Whether there would be or like diametastasis of 50% or not.
I have to say, probably CTFFR has helped a little in that group. At least you have some functional information.
Yeah.
If they don't have that, I just need a stress test.
Yeah.
I mean, more and more, the way calcium scores are being used is 0 calcium score is a good thing, and any kind of calcium is not a good thing.
Yeah, I mean, we usually, if you're 0 to 100, and especially if you're older, we won't start aspirin. If you have above 100, and especially if you're younger, we'll tend to start aspirin. And all of them, if they have any calcium, we'll put on a statin.
Right.
But that's why I think this trial is
Right.
really timely.
Right, but I wanted to have a result that's meaningful and useful.
I had a question for Dr. An about the ENAVO-TAVR trial. When I heard the DAPA-TAVI presentation, no offense to those investigators, but I kind of thought it was a little just like, well, these were patients who happened to have a TAVR, and then they had an indication for dapagliflozin, so it wasn't too surprising that they did better. In your study, are you expecting anything different? Because, I guess it's a newer agent, so that is important, but the drugs already, or this class has been shown to be beneficial, I guess, in HFpEF. And so these will just be TAVR people who happen to have HFpEF, or HFpEF people who happen to have had a TAVR, I guess. Do you think there'll be any difference? Or do you think there's a different mechanism for the HFpEF in the TAVR patients, and that's why it's important to demonstrate that the drug works in that group?
I have to be cautious in this comment, but DAPA-TAVI trial had some problem because those patients, all patients had actually history of heart failure, and those patients are indicated for SGLT2 inhibitor. So it's kind of ethically problematic to exclude those patients or give placebo drug to those patients. So initially, we designed the trial as all-comer for TAVR patient, but then going through the Korean FDA regulatory process, they pointed out, wouldn't it be, ethically problematic of exclude, those heart failure patients who are supposed to take SGLT2 inhibitor. So we kind of shifted our target to HFpEF population who would undergo TAVI.
Okay.
I think maybe they're different than just regular HFpEF patients, because after TAVR, you can see reverse remodeling and you can see reversal of diastology. So there may be something unique to the population if they don't already have HFpEF, or even if they do.
Yeah.
They may not respond the same way that a classic HFpEF patient would if they got a successful TAVR.
Along the lines of the ethical, you said you were including diabetics. How did you deal with that? Like, did you think about maybe we should exclude diabetics because they may have an indication already for SGLT2?
We include all diabetic patients except those patients who had previous SGLT2 inhibitor before, within 4 weeks before randomization. So any SGLT2 1 or 2 inhibitor.
Is Dr. Kong still here? No. Okay.
Other panelists, other comments, questions? I mean, I want to also, really congratulate the Asan Medical Center. This is, just to do one of these large-scale trials is so challenging, and to be able to manage all of these studies, the resources and the research team, it must be incredible. So it's really impressive. But anyway, anyone else have a question or comment for any of the speakers?
Last presentation, when do you anticipate that those results will be presented? You said enrollment is completion in last year, is that right?
Taylor Chip?
Yeah.
When can we expect, Dr. Park, those results to be public?
What is your question?
When can we expect those results to be available for presentation?
Maybe ESC can available in ESC.
ESC in the fall?
2025. Yeah.
Oh, okay. And at 1 year, do patients stay on Plavix monotherapy indefinitely, or do they switch to aspirin, or is that up to the provider?
Based on the host exam study, clopidogrel monotherapy is beyond after 1 year PCI is good option. So we did not. We also more doctors consider determined by doctor or clopidogrel monotherapy or aspirin monotherapy.
Dr. Park, can I ask why your study exclude AMI patients in
because our study drug is ticagrelor 90 millimeter, not 16 millimeter, not 90 millimeter. 90 millimeter in octami, we must use the 90 millimeter ticagrelor, so we exclude the non-ST11 and ST11.
All right. Well, I would again like to congratulate and thank the speakers for their great presentations and interesting studies, and thank you to the panelists for participating and the audience, and hope everyone has a great day.